Dr. Julie Babcock, a graduate of the University of Oklahoma College of Dentistry, has been in private practice in Overland Park, Kansas for 22 years. Along with biological dentistry, she focuses on techniques that allow the body to naturally heal an out of balance or overload chewing system. When the system is in a natural state of harmony, the bite can be beautifully rebuilt using minimally invasive techniques. Dr. Babcock has studied multiple techniques for TMD and occlusal muscle disorders, but the aggressive use of crowns on an otherwise healthy dentition did not follow biological principles. Dr. Babcock studied at the Texas Center for Occlusal Studies in Dallas, ignited a passion to not only continue learning, but to teach other dentists minimally invasive dentistry. Please welcome Dr. Babcock.
Thank you. I do not have any financial interests of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. So, a different spin on biological dentistry today. Here at the IAOMT and other similar groups, we spend a lot of time and energy understanding and practicing principles of biocompatibility and how the mouth and the body are connected. And we do a pretty good job of that. But I question how well we do when we look at human biology and it comes to a healthy chewing system, genetic tooth form, and our bite. I think we're missing a piece of the puzzle here. I was frustrated myself for 15 years as I tried to deal with this, and wondering how were teeth designed and why? How does the joint work and why? How do they work together? And how does it affect the rest of the body? The design is beautiful. It's complicated, and there's nothing random about it at all. And as dentists, especially as biological dentists, I think we should have a deep understanding of this. So in dentistry, when you really boil it down, there's really 3 diseases that we deal with. 1, tooth decay. We do pretty good with that. We know what affects that. We know how to deal with it. We know how to get rid of it. And even those in this room know how to prevent it. We're pretty good at dealing with gum disease. We've got good care there. We've got periodontists. We've got good care in our own offices. Where we're missing some information, though, is this 3rd category right here, occlusion and TMD. I don't think many of you would disagree with me on that. And there's no standard protocol for TMD. You can go all over the place and learn different things, and we all disagree with each other. You join your occlusal church, and then don't listen to anybody else after that, right? So occlusion and TMD, it's feared and it's misunderstood, for sure. The somatognathic system is not well understood by most dentists. It's a complex joint. In fact, it's the most complex joint in the body. It rotates and it translates. It's the only one that does that. There's hardly any of it taught in school, unless you went somewhere that I don't know about. We don't learn much about occlusion in school. It's probably information overload for somebody trying to figure out how to get somebody numb. There's a huge financial investment. I think I've spent more money, I know I spent more money learning how to deal with occlusion than I ever spent in dental school. There's no doubt about that. And the time investment is huge. My family would tell you that that was definitely the truth. A lot of time in hotels, a lot of fun. But even through all that, I was really scared to death of treating any kind of occlusion. People always said, raise the VDO, you have to raise the VDO. Well, who really does that? I wasn't about to do that. I was terrified. And so there's a lot of different places we can go. We can go all over the country, and these are some of our main churches right here. And, they do a pretty good job. They have their good stuff. They got their stuff that, I kind of question. And like I said, I did my fair share of courses, and I learned to make a really good night guard. But what I didn't understand at the time was that I was just making a night guard, even though it was a really, really nice one. So our traditional TMJ specialists, they're experts in pain management. They use a lot of drugs, muscle relaxers, pain medications, anti-inflammatories, Botox, yep, been there, splint therapy for symptom relief, and management of symptoms, but ignoring the root cause of the problem. Why does somebody need a night guard to begin with? And rarely, if ever, is there a long-term solution. So I stumbled across this guy here, the late Bob Lee, and he studied biological design of the somatognathic system from a different perspective. He looked at health. He took a whole bunch of really healthy people. They had no wear on their teeth, no problems there. They had completely healthy joints, no breakdown, no pain, just no symptoms at all. And he wanted to know what they all have in common. And we probably ought to figure out what that is so we can replicate it. So he figured out they had unworn, pristine teeth. They had proprioceptive anterior guidance, so they knew where their bite was going to go. And they have stable condyles. And so as biological dentists, shouldn't we mimic the system as designed as closely as possible? This is absolutely beautiful. The soft tissue is beautiful. The teeth are beautiful. The cusp tips are sharp. The embrasures are perfect. The interproximal contacts, everything about it is perfectly right. But how rare is that? I see that in my office maybe twice a year. It's pretty unusual. This is where we live. If your practice is anything like mine, you see this every single day, but we treat it as health. It may be stable, but they may not be in pain, but that's not healthy. So what do we treat? We treat cavities, gum disease, we put sealants on, we do braces, we do all kinds of stuff, but we really don't look at that as a system that is absolutely breaking down. What we do when we have a broken back tooth is we put a crash helmet on, something kind of like those crowns up there, crash helmets. They don't really fix anything. It's like if you're riding down the road on a bicycle with a bad wheel and you fall off, you get a concussion, you're going to wear a crash helmet next time. But if you get back on the same bike, you're going to fall off again, you're going to break an arm. Now we're going to do a crash helmet on your arm. And it just goes on and on and on until you have a much bigger mess. So in a perfect bite, we should have perfect canine guidance and protrusive guidance. And you cannot leave this up to the orthodontist. This is absolutely the general dentist's responsibility. I was really surprised when I first started learning this, and when the instructor stood up and he said, as long as there's orthodontists out there, we're going to be busy fixing their messes. And I didn't really understand it at the time, but I do now. They straighten teeth. They straighten them really nice, but they have no concept of what's going on in the joint. And they straighten people in and they lock them in to an unstable joint, which then causes problems. But the problem then, 10 years later, when symptoms happen, these patients are in pain, breaking teeth, and everything's falling apart, orthodontist is completely out of the picture. Nobody looks back there. So contact points, they're definitely not random. These contact points dictate the position of the condyle and the fossa. When we close together, those contact points determine everything. So let's look at normal joint function. So this is normal. And for anybody, if you don't recognize this, these are Bite FX videos. I love these animations. I use them every single day in my office. Bite FX. I'm trying to find my mouse. I don't know where it went. So what we have here, when this model here closes, all the teeth absolutely touch. And when we open about 22 millimeters, that's rotation. If you look there, the condyle doesn't go anywhere during that first 22 millimeters. It's after that when it starts to translate that things start to come apart. And that's completely normal. So when that's rotating at that first 22 millimeters, that opens and closes like a door. It closes in the same exact spot every single time, and there's no variation for that. That's stability. If it's moving, if that's not stable and we're not functioning like a hinge in there, every time you close, it's in a slightly different place. You've seen these patients, they come back 6 times for filling adjustments. You did a little occlusion in 18, and you're on appointment number 5 for adjusting. That's why. So in a live model here, I cannot find my mouse. Icon here, there it is. So in a live model here, I've got the condyle drawn right in here, and then the fossa, and then there's a biconcave disc in between. So this is completely normal and stable. So we open, goes down and forward, disc comes with it, it comes back up into the fossa to the same exact place. And it does that over and over every time we open our mouth. Okay, so we've covered teeth and joints. Now we're going to talk about anterior proprioceptive guidance. This is some interesting things. So proprioception that's the specialized sensory receptors in the body that monitor the position of the body in space. So for example, we would know where to put our mandible because we have highly defined receptors in the pulp and in the PDL. And in fact, they're 100 times more proprioceptive in the lower centrals than anywhere else. So if there's crowns or veneers on the lower central teeth, you're going to have less proprioception and there's less control over that mandible. And of course, it's all unconscious. And then teeth are embryologically developed from the same place where the brain comes from the neural crest. So they're like calcified neurons. And so the brain is very, very protective of the teeth. The teeth will always win. Muscles will break down, joints will break down, all kinds of other things will happen before teeth touch that aren't supposed to. So in dental school, I can tell you one of the things I think we should have learned that we never did was how we chew. How on earth do humans chew? Well, let's look. This is a pathologic bite. And so if we look here from the side, the mandible is coming out, it is crashing against that canine and then coming back into place. So what's the problem here? Why are the canines worn? Why is the enamel breaking down? Is it soft enamel? Is it grinding or other habits? No. The teeth aren't the source of the problem. And maybe a night guard would help. It would slow down the destruction, but it isn't going to fix the problem because the problem is not with the teeth. There's a lot of lateral forces going on, and there's too much vertical force. So this one here is a completely healthy and restored case. Cusp tips are sharp, and everything is completely different going on here. And if you notice, nothing touches until the very end of that chewing stroke. The mandible comes up, and then they touch, barely, if they touch at all. And the mandible doesn't move side to side. We don't chew like cows. There's just a 3 millimeter movement side to side. And isn't that nice? Side to side and front to back. But you can look here in slow motion. Nothing touches. So the chewing stroke. It is retrusive. How do we check bite at a home office? And protrusive. We have them squeeze and grind and push, but it's actually a retrusive motion. It only moves 3 millimeters, side to side and front to back. Now, it can move further, but we only chew in a very small motion. And the teeth hardly ever touch, they just propriocept. Now, if this is the case, and we create this in the chewing system, then why do we need zirconium to prevent breakage? It's unnatural, and it's unnecessarily destructive if your bite is balanced. If you're chewing like that one that's restored, you don't need that stuff, okay? Okay, so this is a little bit different one. There's a little bit of pathology going on in this one. So if you notice here, the joint looks stable. It's definitely centered. But when this one comes together, the back teeth are going to touch first, all right? So if they touch first, your brain doesn't like that, so we're going to take some pressure off of that and get our front teeth together. So now we're doing this. If you look at the joint, it keeps getting pulled out of position. The superior belly of the lateral pterygoid is pulling on that disc, and that'll eventually lead to a displaced disc. And if you can imagine over time, what's going to happen to those back teeth? They might need a couple of crash helmets, right? Cracked molars, broken porcelain, every time. So this is a pathologic joint here. So we have the same situation going on, but it's not stable. So you can see where that disc is popping off and on the condyle. It's getting pulled forward, and it's anteriorly displaced. Okay, so proprioception, let's look at how that works. So if you remember, our teeth and our brain are very, very tightly connected, and your brain is not going to let you smack back teeth together. So if we close together, right there, that's going to send that signal to the brain that says, hey, we can't let that happen. So we're going to have to shift forward or to the side or somewhere else to avoid that. That then pulls that condyle out of place. And now we're smacking on front teeth. Can we say broken veneers, anterior fillings that won't stay in, chipped front teeth, all that kind of stuff happens right there. And eventually, we just skip right past that, and go right to that position right there. We never even know it. But that's also called the CRCO slide. So occlusal interferences are a big problem here. The muscles of mastication cannot relax the protective bracing contraction as long as the occlusal interference is present. It's very strong. And that pattern of deviation is reinforced every time contact is made, and it's retained in the brain's memory bank so that muscular closure into the deviated jaw relationship becomes automatic. The good news, though, is that proprioceptive memory is it will fade rapidly with continual reinforcement if there's the continual reinforcement stops. So let's look at this. We see this every single day in our practice right here. This is a guy, I actually just saw him last week. And so we look at a pattern here over, I don't know how many years, a long time. We already have a crash helmet here on 18. We've got 30 and 31 both broken. Those were lateral interference for sure that eventually broke off. And I bet you those didn't happen at the same time. So this has been happening under the supervision of a dentist for years and years and years. And it happens all the time. And I mean, that's okay. It's just that we need to let our patients know that there's some problems in there that are going to get worse if we don't treat it. And I think a lot of times our patients are in the dark, and I think that's because the dentists are in the dark. So why are we using zirconium? There's no give to zirconium like there is with enamel over dentin. It's not a natural substance. It's way too hard for the teeth. And when anything in nature is out of balance, the weakest component of that system is going to fail. If you put zirconium on 19, 14 is going to break, or that force is going to go somewhere else. It may end up in the joint, it is going to go somewhere. You can't just make it go away by putting a zirconium crown on there. So the weakest link is always going to fail. Usually the opposing enamel. We've all seen this. These are crowns on front teeth. Now the porcelain is chipping, the lower teeth are worn, and we've got a mess. So what do? I mean, I can replace those veneers or those crowns maybe, but are they going to continue to chip? Yep. What about the lower anterior teeth? Do I want to crown those or veneer those? Nope, not really. Those are going to be coming off. I know they will be. So how do you fix it? This is somebody you're going to have to raise their vertical dimension. But if you raise it where they are right now, we're going to be right back in the same mess. So let's think like the conservative biological dentist that we are. This is the same patient within about a 4-month time frame. This doesn't look so bad here. This is a 20-year-old boy in college. He was in horrific pain. He couldn't open past 20 millimeters. He couldn't sleep, and he was hurting. And so I was able to restore him using flowable composite. We got his bite stable, created a little bit of opening in his bite, and put some flowable composite in there. I would never, ever, ever want to, mow his teeth down and put zirconium on there. That would be horrible. So it's time for a new paradigm. Let's call it what it is: enamel amputation. We're going to have to amputate. I can't imagine putting a high-speed burr on that beautiful girl's teeth. I mean, her smile has a few little things in there that aren't perfect, but to put a burr on those, I can't even imagine doing it. But somebody did. And it's not a horrible result, but my question is what else could have been done? She's young, she's beautiful. Not my favorite result. How about this guy? What's he, 14 maybe? I can't imagine, I don't know how you do that right there. Those teeth aren't biologically formed. The dentist and the lab tech didn't really know what teeth are supposed to look like. And now this 14-year-old kid's got to deal with this for the rest of his life. And if you look at his face on the before picture and the after picture, look at his eyes. Look at the difference. So something is wrong in his system on that restored picture. That's going to fall apart. So this one here, it's not a terrible result. He's a young kid, and I can't imagine putting crowns on his teeth too. I mean, they obviously increased his vertical dimension, that's fine, but how about maybe 4 veneers and some composite on the rest of the teeth? That would have fixed the aesthetics and the bite without having to cut all those down. So as biological dentists, wouldn't we be the ones to understand the importance of diagnosing and treating the chewing system at the root cause and doing it conservatively? I think so. So here's how this works. If we take a bite, and I can fool the brain into thinking that the bite is perfect, there's no interference, there's nothing in the way at all, by using a properly made splint. When you close together on that, now if I adjust that, and they wear it 24/7, they eat it and everything, close together, that jaw is going to go right back into place. See how that just goes home like that? Let's do that again. Right there. That takes usually about 8 to 12 weeks of full-time wear, and I'll see the patient at least once a week to adjust it to allow room for that condyle to go back to place. Once that happens, the splint comes out, but now we're back to problem number one. We still have an interference right back there in early contact. But that's actually okay, because our condyles are stable, and that gives me the vertical space I need now to add composite to those teeth. You'd never want to put composite on this without having an absolutely stable and proven joint position. So how do we do this? I use an appliance called a C2O. It looks like a regular night guard. It's worn on top, a condylar centering orthotic. And what it does is, one of the first things it does is it mimics the contact point. So when the lower jaw comes up, there's absolutely no interferences in there at all. And we've got our canine guidance and then our racing stripes in the front, which is the protrusive. There's no interferences, and that then allows the brain to be fooled to allow that condyle to go back home. So, night guards, symptom treatment only, which is fine. There's nothing wrong with treating somebody's symptoms, but we just have to understand that it's not really doing anything. Okay, they can be soft, they can be hard, they can be in the front and the back, and the top and the bottom. They come in every different style and even color. And I'll never forget, I was in a study group in Asheville, North Carolina. There was 8 of us sitting around a table, and we were patting ourselves on the back because we were making such great night guards. And the leader said, we're not really treating anything. We're just slowing down the destruction. God, I never thought about it like that, but he was right. And I didn't like that very much. So when I realized that we were just managing but not treating the chewing system. So what is managing a chewing system and not treating it? It's a bite splint worn only at night. Doesn't matter what kind it is. If you're wearing it only at night, as soon as you take it out in the morning, the interferences come back and everything comes right back out of place again. They may be comfortable, but that's fine. But haven't you all seen somebody wearing a night guard faithfully and they still break a virgin number 18? I have. I saw it a few weeks ago. So it may improve the symptoms, but the cause is still there. And you'll cover up the symptoms at night, but everything continues to break down. And these people also have repeated chiropractic appointments, massage therapy, stress management, pain management. They tell me they see a chiropractor every week for years and years and years. And they'll feel good for a few days, but then it comes right back. So, and night guards don't do what we think they do either. They may slow down the destruction, but this patient wore a night guard faithfully for 9 years, and they obviously still broke down. So this is obviously daytime functional, not necessarily nighttime grinding. So who are these patients in our office? We've got to be a little bit curious and figure out who they are. They're not that hard to find, actually. These are the ones that come back multiple times after a filling or a crown. They have cracked and broken teeth or porcelain. We see this probably every day if your practice is like mine. The anterior filling that just won't stay in. The crown that keeps coming off. Anterior wear, posterior wear, or both. This is a fun one. Second molar crown preps, you get the call from the lab and they say, hey, why didn't you reduce the occlusion? And you know you did, but now it's gone. What happened is the joint seated. That was their first point of contact. It's gone. And then jaw pain and headaches after dental work. They think that you messed up. All of a sudden, they are in horrific pain. They're taking narcotic drugs, and if their broken tooth that you're fixing is what we call the GPS tooth, the one that has been guiding this adapted system for years and years and years, and you go and change that can throw the whole thing out of balance. So this is what we see every day, tongue scalloping. I've heard of this being vitamin deficiencies. Maybe there's a link there, but what I think it is those scallops go right along the linguals of the lower molars. And what we'll do with all these other muscles that are so tired and so overworked, we'll bring the tongue in, it'll push and brace against the teeth. It gives those muscles a little bit of break. They never know they're doing that, but you'll see this all the time when you start looking for it. But 4 bite extractions. If you had ortho done in the 80s, you have 4 bite extractions. Almost everybody in that situation has problems with their bite. A brand new diastema, right there between 8 and 9. Have you ever had a patient come in and say, yeah, I didn't used to have this space, but over the last year or so, I've got this space in between my teeth? Well, it's that tongue. It's that bracing and pushing. Anytime we see broken teeth or just a little bit of canine wear, if that little bit of wear there creates less of a vertical occlusion, and so you've got a higher chance of lateral interferences in the back. And this right here, the intrusive tongue. You have them bite together, you have them go into a canine or protrusive position, and the tongue sticking out, they're bracers. They've got some problems. So when you see something like this come in your office, you got to ask a few more questions. This lady came into me, and she was wanting a bridge for the upper right. And the first thing I needed to do was tell her that we're going to be doing an implant, not a bridge. But the other thing is look around a little bit. Okay, 14's got a crown, 19's got a crown, 30 has a crown. A couple of them have worn porcelain in them, and I'm starting to ask a few questions. How did you lose that tooth? Oh, the root broke. Oh, okay. Why do the other ones have crowns? Oh, they had fractures. Huh, okay. Interesting. Maybe there's more to the story. Well, back to that same patient. Intrusive tongue, scalloping in the tongue, passive eruption right in here, and then right there, that dagger cusp sticking down. That is very likely the interference. And what else can we see? The intrusive tongue, but also this is the passive eruption. So on these lower anterior teeth, when you see that right there, if you draw a line from the gingival to the gingival on the canines, and those incisors are going up higher than that, what's happening is those incisors are chipping. You've got that anterior positioning, it's wearing those incisors down, but they have to have their contact, so they keep erupting, and then you wear it down some more, and it erupts a little bit more, and you wear it down some more, and it goes on until we have this situation going on right there. So this is the lady's face. And so now I got to think, if we're doing an implant or bridge or whatever right there, I've got to think, what's going to happen? Is the implant going to fail? What about number 30? Are we going to break it? Are we going to have bone loss around that? I just have to start thinking. And so those are the questions I asked the patient. And fortunately, she saw my point, and we went ahead with treatment. But a lot of times when you bring up to patients, if they come in with pain, chances are they've had a night guard before, and that might even bring you a bag of night guards and explain how night guards don't work for them. Well, that may be true if you were in the wrong night guard, or not really the wrong night guard, but it's not adjusted properly. If they're worn, any soft night guards at all are going to make everything worse. But they've often been through a lot of treatment before. So when you're making an appliance, there's a couple things that have to be there. It has to be absolutely flat. You can't have any V's or anything in there that's going to introduce a lateral interference. That will cause problems every single time. And then around the front, it's got to be sloped a little bit to allow for disclusion of the posterior teeth. So it has to be a minimal stress occlusion and permissive. You can't lock anybody in. Even little dimples in there that grab the cusp tips, those little dimples are little interferences that if you have somebody that's inflamed, that can cause some problems. It has to be absolutely flat. You can never, ever force the muscle into any other position. You can't force it front. You can't force it to the side or anywhere. That's going to cause inflammation, spasm, and cause pain. Everything has to be very, very permissive. You never want to incite any muscle hyperactivity. So this is what one looks like with the bite. All those contacts are perfect. And then we have our canine guidance and once again our racing stripes for the protrusive. And if they're wearing this 24/7, you do need to make these as thin as possible. So it's important that it follow the contour of the teeth and the lips. And what we find is with these patients that they can't live without it.
Headaches and facial muscle pain due to a bad bite. You can see how when the patient puts her jaw out to the right and the left, the jaws shake. The muscles are very tense and hyperactive. This is very painful, causing chronic headaches and facial pain. Now this can be treated by use of an orthotic. As you can see here, with the orthotic end, the bite is stabilized, and when the patient moves her jaw from right to left, there's no more tension in the muscles. The jaw doesn't shake, it's very comfortable.
All right, so that's an immediate effect. And so I've got a couple other examples I want to show you here that are just not biological. They may work some of the time, I don't really know, but when I look at this and I think, okay, you're pulling the jaw forward and you're locking it into place. This particular patient had been in treatment for maybe 2 years wearing this appliance and she wasn't getting any better. Or something like this. This was a 2-piece thing. I don't know why it was in 2 pieces, but you see all the interferences in there? First thing I did with this patient was she came in just terrible pain, and she'd been in pain for about a year with this thing. I took it and I said, well, you mind if I make a few adjustments on it? She's like, whatever you want to do, it's killing me. So I took it and I just whacked it off. I just got it all flat and I made sure everything was even. Immediate relief. It didn't take days, it took seconds. And it was pulling her into a down and forward position. I don't know why they do that. I guess they want to get pressure off of the retrodiscal fibers, but that has to be a very, very temporary thing. So there was a failure there for an entire year to resolve any pain. So this is about the flat burr. A lot of times you'll see these other kinds of burrs like that when they're on your right. They can't have any curves in them like that or they're going to cause interferences. You have to have a flat barrel-shaped burr. It's really important to do that. So this lady was interesting. It was hard for me to get this picture of her. She'd been in pain for 6 years and getting worse and worse and worse. I could hardly get that picture because her mandible was quivering so badly, just in a rest position. I felt terrible for her. She had 3 different appliances from the same dentist, and she was to rotate them. When the first one hurt bad, try the next one. When that one hurts too bad, then try the next one, and then just keep rotating them as you go. And she was a miserable, miserable person. They were all forcing her down and forward. She had this blob of acrylic right here that was crowding out her tongue. That was locking her in a forward position. It wouldn't let her move. She obviously couldn't move with this one. And this one here, there's no possibility for anterior or canine guidance right there. So what do we have? We've got a bumpy, appliance back in here with no anterior guidance. So she's bumping off those back inclines in that acrylic, and it was killing her. So there you can see it again where there's no anterior guidance. And if you look here, I marked the occlusion. It was way too heavy on one side versus the other. If these aren't completely balanced on both sides, there's going to be problems in the joints. So you've got to be really careful with who's adjusting these appliances. If it's you, if it's your staff member, they've got to really know how to do that. And when they're holding that burr on there, you can't tip it in. You have to run it flat across there or you're going to introduce more interferences. So this is another appliance, the same thing. She was too heavy on one side, barely hitting on the other, and causing her terrible pain. So this is another issue, is they went ahead and did completed case. The veneers were there before they did all this, but those lower back crowns were done before she was out of pain. I would never, ever, ever restore anybody. If you can't get them comfortable in an appliance, why would you put crowns in? I don't know why they did that, but it made her worse. And those crowns aren't biological at all. The form of those are not human teeth. I'm not sure where they came from. So this is a completed occlusion, and the same thing. She was hitting in the same spots as the appliance. Too heavy on the right, and not enough on the left. 3 contacting teeth. Nothing biological about that, and that patient was definitely not well. So I got her into a well-made splint, and she got her life back in probably 3 or 4 weeks. So here's an example. This lady came in, and she has a lot of pain. The middle picture there was immediate delivery of her appliance. And if you look at some things here, you can see a different position of her eyes. You can see her head position change, because now she's got a better airway all of a sudden. And then that last picture there, and her face is much more relaxed. The last picture is a finished case, and you can see the same head posture and the same facial positions. She's way happier, way healthier. This one too, this is immediate delivery of a splint. If you don't even look at the mouth and just look at the eyes, there's a huge difference. And look at her face and the tension of her face. See how it's kind of going off to her right side? That's already getting better with that appliance. So what is stable or condylar position? You have to remove all the posterior interferences and give a permissive and meticulously adjusted appliance. And the body will heal itself when we create the proper natural biological environment. And that's what I love about this thing, is the body will heal. You just got to get stuff out of the way. And you never force the condyle to go anywhere. You just allow it. And it's amazing. It knows where to go. You don't have to show it. So, and it has to be a very stable and repeatable position. And it has to be comfortable. So when we're done with the appliance therapy, if we look at these pictures here, this is before and after appliance therapy. The first one, you can see the midline is off, but the 2 on the right there, that was our stable position. Our midline is now right back on, and we have space right there. which is awesome. That's exactly what we want. We wanted to increase our vertical dimension, and we were able to do that really easily because now we have the space to work with. Same thing here in this case. We have our maximum intercuspation before we started, and this is after we were stable. Right there, we've got the space that we need. The same thing right here. This patient came in, and it's like I could Julie bite together, and she bit together, and that was her bite. Looks pretty normal. No orthodontist is going to touch that, but she was in horrific pain. She was a high school biology teacher. She couldn't talk for an hour without having to stop and rest her face. So the lower picture was, after we were done with the splint therapy, I said, okay, Julie, bite together. She's got one contact point right back there, and she's perfectly comfortable as long as her splint's in. And if you look at the midline from here to here, her whole jaw went like that over a period of about 4 months in adjusting her appliance. So there's a whole other component going on in here. We have 2 cranial nerves that are involved. We've got 5 and 7. Cranial nerve 5 is controlling the muscles of mastication. 7 is controlling the facial nerves. And they come out of the brain really close to each other, and so they affect each other. So if the muscles of mastication are overfiring and overworking, that's going to create the same effect in number 7. So we have weird facial pulls. We have lip lines that are off and unbalanced like this. This is a before and after here. I didn't do anything to her gums. We just got her bite in line and got the muscles to relax, which then relaxed the facial nerves, and everything is now balanced. And this other lady too, that was a very sick woman. Now look at her eyes. That's all because of that facial nerve number 7. Same thing with this lady here. If you look at her smile, before and then after, all that tension is just gone, and now her smile looks normal. So this is Amy. This is a really interesting case. She came to me at 15 years old to have her teeth cleaned. And I was like, hey, Amy, how's your summer? It sucks. Okay, well, what's going on? She says, well, my wrist hurts. So my right wrist, it hurts me really bad. I was like, well, what's going on with that? And she says, a nerve pain right down there in her wrist. And I said, well, that's kind of interesting. I'm not sure what I can do about that, but I asked her a few more questions, and I actually reached up and I touched her right here. She just looked a little off to me. If you look at that picture, she just kind of not real symmetrical there. She's got that ear pull on the right side. Her head's a little bit tilted. She's just kind of off. So I felt the urge to go up there and touch her sternocleidomastoid muscle, and she about punched me. It hurt her so bad. And so then I asked more questions. Do you have headaches? Yes, all the time. She can't sleep because she's in so much pain. It's absolutely debilitating. This girl is a very talented cello player, horseback rider. She hadn't done any of that in a year and a half. She goes home and she goes to bed every day. And so if we look a little closer, we have the head tilt, the ear pull, the tension in the face and the eyes, asymmetrical smile. Something's off. So what'd she do? They start like everybody else does. They go to the MD. I wouldn't go to my dentist for wrist pain, and neither did she. But she'd been dealing with this for a year and a half, and she'd seen multiple doctors. She'd seen neurologists, and she'd had MRIs, all kinds of stuff. All the medical testing came back inconclusive, and they only checked her wrist. They didn't go anywhere else. They didn't look at anything else, and they told her it was absolutely not coming from her neck, for sure. She tried physical therapy, multiple medications, and they settled on a diagnosis of, any guesses? Depression. Yes, absolutely. And so what do? Antidepressants. And does that help her? No, not at all. So she's working with chiropractic, physical therapy, all this stuff going on, and now let's go look at her teeth. So this is her first bite right here, just bite together. You can see her midline is off. She's got canine wear, but not a lot. I mean, you look at this kid and you're like, yeah, she didn't have a whole lot going on there. It looks not too bad. Her first point of contact was on her left side. She had a really big COCR slide, and she had a lot of tinnitus and stuffiness in her right ear. That was her smile. Definitely off. Something's not right there. I don't know if you guys take this photo or not. This is a good one to do. It's called an occlusal profile, and you take it because you're looking for dagger cusps hanging down from the top or the lower on this buccal cusp, and they rotate in, they stick up too high and create interferences. You can see them really well with that picture, and it definitely shows up here with those big daggers hanging down. So when she goes into her test positions here, her right canine position, she's banging here, she's hitting all over the place over here. When she goes to the left, she can't even get her canines together. Everything is going on right there. And she's just tremoring as she goes there. And protrusive, look what her midline does. She just goes off into one side. So after getting her into her splint, I'll never forget this. At 15, she was pretty wise. I was like, how does that feel? And she's got this big chunk of plastic in her mouth, and she goes, well, I don't know. It feels kind of weird, but it just feels right. And the thing is when I make these appliances, I make them in my, what we call CR du jour. It's kind of my best guess is where I manipulated her mandibles. And so I kind of guided her back and made it right there. So I put this thing in, and it looked like I mismounted it, but when I put it in there, it felt really good. So let's hear what she has to say about it. This is Amy House. Amy, how old are you?
I'm 15.
15. Okay. Tell me what you've been dealing with for the last year and a half.
For the last year and a half, I've been dealing with constant headaches and insomnia problems and wrist problems, and I haven't been able to play cello for about a year now. So yeah.
Tell me more about your wrist. What kinds of things were you feeling in
And
your
I
arm
was
and hand?
feeling like shooting pains whenever I'd play cello, and just when I do anything really, and it would go numb sometimes, and then it started going up to my upper arm, and then into my shoulder, and then into my neck. It just kind of got crazy out of hand.
Okay. What kinds of doctors did you see, or what did you do over the last year?
I started out with physical therapy because I had a wrist issue about 2.5 years ago, and that was just a muscle issue. So I went and tried to do that, and since none of the physical therapy was working, we went to a specialist, and they did an MRI and an EMG, and they didn't find anything on either of those. So
you were kind of out of luck.
yeah, definitely.
And then what happened?
And then I had just a yearly dental exam, and I mentioned something about my wrist hurting and not being able to play, and I think the dots were just kind of connected here about, my midline was off and my jaw was not lined up, and I think we just kind of connected the dots from there.
Yeah. Okay. So, what have you been wearing in your mouth then? Can you tell me a little bit about that?
Wearing the splint,
Yeah.
which is amazing.
Yes. How long have you had it now?
3 weeks.
Okay. And what have you noticed over the last 3 weeks?
My headaches and my insomnia are basically completely gone, except for when I need an adjustment, which then I'll get a headache, and it's not too bad, but it lets me know that I need an adjustment. So, and my wrist hasn't been hurting when I play. I just need to rebuild strength, but it hasn't been hurting, and that's huge that I'll be able to play cello again.
That is pretty awesome.
Yeah.
Yeah. Who would have thought it'd be your dentist, right? That's great. Thank you. Yeah, so what's going on with the wrist here is her muscles of mastication were so tense and so tight, even the ones in her neck were pinching, and it was pinching off a nerve coming down through her neck, down into her arm. And when that released, as soon as I took those interferences out of the way, it just let go, and within days, she felt better. And splint therapy, it shouldn't take a year to get somebody out of pain. I mean, really a couple days, it should be better, maybe over a few weeks, but there should be a rapid improvement. And if that's not happening, something's wrong. Something's not right with the splint. So hinge axis is important too. When I said we've got stable condyles in there and we're rotating, we rotate on a hinge. It's like the center of a bicycle wheel, the one spot that doesn't move. You have to be able to stabilize that condyle to the point that you can find it. When they open and close, nothing is moving. It's all just right there in one spot. It's quite the contraption. You can see that little stylus.
Okay. Drop, close, drop, close, drop, close. Perfect.
So it doesn't move. I know I'm on the hinge, and then I know I'm good to go. And there are several fail safes along the way to make sure that we're absolutely perfect, because there's really no room for error. If we're building an flowable composite, we can't be close. We have to be on the money. So this is an interesting photo too. This is her initial maximum intercuspation where we started. The second one here is what I call CR du jour, or basic CR. And this is what a lot of schools will teach. They'll teach how to get to CR. You maybe put an NTI in for a day or a week or a couple weeks, or maybe romance the mandible back up into the fossa. And you're going to get something that looks kind of like that. It's close, but not really. When we get down to the hinge, we have another whole 1.5 millimeters to where we're really stable. So if I would have restored the middle one in composite, that wouldn't have worked very well. And so she started with her, when we measure from the CEJ to CEJ at usually 8 to 25 or somewhere in that area, normal is about 18 millimeters. And she was coming in at 14.3. That's really small. And so by the time we were done with her hinge, she was at 17.5. Now I've got room to work. This is really great. So what we do from here is we do a wax up. And we wax up in areas that we need it. We don't have to do we don't have to do anything else. We don't have to cut crown preps or anything. We just add where we're missing tooth structure. And once we do that, we use a material called Lumalock. It's a clear, it looks blue here, but it's really a clear, like a putty. And we form it over the wax, and then we drill holes in it, just a little, like the size of a 55 diamond. And so when you're ready to restore, you can transfer one tooth at a time. You put the Lumalock tray in, you squirt in your composite, you cure it, take the tray out, clean it up. One tooth at a time. It takes a long time, but it looks kind of like that. And so that's our first tooth. Most of these cases take about 2 days to get through, some a little less. But I don't want to crown this girl's teeth. That just doesn't make sense to me. But when the system's in harmony, we can do it. Zirconium isn't going to be necessary at all. So there's our upper, there's a lower. That blue in there, that's called a validator. It's made of acrylic off of the wax up. So I just know that we're dead on the money there. We don't have anything messed up. So by the time we were done, we have our test positions. The camera angle is a little off here, but there's no interferences at all in either of those test positions. And our occlusal contacts are absolutely perfect. And if you look at our before and afters, if you just focus in on her eyes first, we have a sick kid and we have a well kid. And there's a little bit of change to her teeth, but not much. And the same thing here. And you can see a lot of changes in her lips and her jaw position here as well. You can see on the left ones, it's too far forward, and then it just floats right back to where it belongs, and everything just falls into place. It doesn't look like a lot of change, but that's all she needed. So these next few, I've got the teeth blacked out because I want you to look at everything but the teeth. Look at the eyes, look at the shape of the face, head positions, head tilts, everything but the teeth. That was over a 4-month period. This is the biology teacher I was talking about. She's 24. She was in horrible, horrible pain. Now she's completely comfortable. I restored her. That's been about 2 years ago now. She's doing great. I haven't had any problems at all. She's the one that went from those two positions. And in our models here, you can see our original maximum intercuspation there on the upper right, and then our hinge position on the bottom. But you can see on that hinge mounting what that contact looks like. And if you can imagine that in her mouth, every time she's trying to close her teeth together, she's trying to avoid that big monster cusp hanging down, and that's what was causing all of her problems. So this is her beginning and then her end. And that gave me the room I needed. Now this one was a major addition, and I don't think I'll ever do one this big again, but we added a lot of composite on her. But like I said, it's been 2 years, we haven't touched her. And she's doing fine. She's completely out of pain, totally stable. And look what it did to her profile. And once again, look at her eyes first. And look at her chin and her head position. She couldn't breathe, and then she's down to a normal position. And I did not put a burr on her enamel. It looks like she had a lip filler injection, but what she has now is normal length lower teeth, and so there's support for the lip, and it makes it look fuller. So this is before and immediately after. The lip just, it knows right what to do. I'm giving her back a biologically normal bite for her body, so there's no encroaching on the lip or any problems with too long the teeth. This one, the head tilt went away. So we started on the top there. That was her original bite together bite. And when she was stable, On the bottom, that's what we've got. She's sitting on one tooth in the back left, and that gave us all that space then to restore her at what we call our first point of contact. And if you see the smile pictures here, look at the lips and the tension of the lips and how different that is. And once again, I didn't put a burr on her teeth. I just added back what she'd lost. Her chin position's different, her eyes are different, head posture, tension, everything is different.
Okay, this is Andrea Valley, and we finished our final restorative, what, a month ago? About a month ago? Okay. And we started about a year ago. So
Yeah.
It's been a long haul. So Andrea, tell me what it was like when we first met that first day.
That first day, I was in a lot of pain. I couldn't open my mouth past probably about here. It wasn't far because I was having a lot of trouble eating. When I did open my mouth past that point, I got a very loud kunk on the left side, which was incredibly painful. And I was pretty hopeless that anyone would ever be able to fix it because I'd been to chiropractors and lots of different people who all said, oh, that's bad.
Right.
And that was all the information I had.
Right. And you didn't really come here expecting.
I didn't come here for this. I came here to get my teeth cleaned.
Right.
Yeah,
Yeah.
because I wanted a biological natural dentist.
Right.
Yeah.
Okay.
And so, and then you said, oh, that's a problem, and I can fix that. And I kind of didn't really believe you.
Right.
I was like, oh, okay, sure. It's like broken, so I don't know how you're going to fix it without surgery, but you were convinced that you were going to be able to fix it. So,
Right.
yeah.
So we got the guard in.
We got the guard in, and then I was converted to a believer pretty much within 3 days.
Yeah.
Yeah.
Pretty
Within
linear.
3 days, my pain went from a 10 down to probably about a 3.
Wow. It didn't take long.
No.
Pretty easy to convince.
Yes. Yes.
Okay, so we did our restorative process about a month ago. Tell me about what it was like to be here for 2 days.
Right. Yeah. Well, you know, as a busy mom, it was almost like a break for me. But it was actually pretty relaxing. I mean, I think that numbing all of this really helped. There was lots of numbing across here, and with the what do you call that thing that you expanded my
Yeah.
face with?
Yeah.
Okay, so that opened everything up, and I could really just kind of relax into it and let you do all the work that you needed to do, which I think helped you go a little bit faster.
Oh, definitely.
With that, I
Yeah,
was
we
just-
actually moved at a really good pace.
We got almost all of it done in 6 hours.
Yeah. We had to do some finishing up the next day.
We
Quite a
had,
bit.
I think 3 or 4 hours of adjustments the next day.
Right.
But we got most of it done in about 6 hours, and it was. I was shocked after I saw, you know, we did the first 2, I think, and then I looked at it, and I just couldn't believe that I was actually missing that much teeth. I was shocked.
Yeah.
And I took a picture, and I show people that picture now, and they're just, what? They're amazed.
Yeah.
That I was missing that
How
much
did
teeth.
you live like that?
How did I live like
How
that?
did it become so normal? That is one of the things that's
Right.
amazing. So,
Right.
How did you feel immediately after, like that first night, second night?
There was still a little bit of tension. I felt like getting my bite to exactly that point was a little bit tense the first night. And then I said, oh, I think some things are hitting on the front. And you said, no, it's the back. And
Yeah.
so we fixed the back, immediately went away.
Yeah.
And so probably by the second night, I would wake up in the morning and it would be completely seated. Is that what you said?
Yeah.
It was
Uh-huh.
completely perfect.
Awesome. And so from the last month, gosh, we haven't seen each other at all.
Right.
Really no issues.
No, the side to side was conking on that one spot,
Yeah.
and that was really
One
it.
place to work out.
Mhm.
Super stable.
No
super
problems.
comfortable. And tell me about what you noticed in your body throughout just during this whole process.
Well, my craniosacral therapist also noticed, and I did as well, that the hips were a lot more stable from really the moment that we put the mouth guard in. That changed everything. So more stable in the hips, less back pain, less lower back pain, less shoulder pain, less neck pain. My neck pain that I had pretty much ever since I can remember completely went away with the mouth guard.
Wow.
Gone forever. So I used to have to go to the chiropractor a lot. I was always looking for this adjustment that would kind of release the pressure, and it would work for about 3 days.
Right.
And then it would come back, and then we put the mouth guard in, and that went away after about a month completely. And then I haven't been to the chiropractor since.
Wow.
Yeah.
You don't miss that.
No.
You're gonna like spending
Yeah.
money on that too. Okay, this is Andrea Val.
Yep. Again. So I've got a couple, I know we're running close on time here. I've got a couple more pictures, the same thing. Look at the face, and then we can look at the teeth first. But look at the head tilt. Look at the eyes, how they've opened up completely different. Minor changes on the teeth. It wasn't much, but I wouldn't want to cut her teeth down. There was nothing wrong with her teeth. She just had a lot of problems with her bite. And she said she was in tears when she came back after it had been about a month. She goes, you have no idea what it's like to not worry about where I put my teeth. For years, she thought she was supposed to put her teeth somewhere because she was just so unstable in there. And when we fixed that, it was just like the weight of the world coming off of her shoulders. Same thing with eyes, shape of the face. We've seen that one. Tension in eyes. It's a recurring theme. And that's how we know we're biologically stable. Everything changes. It's not just the teeth. And there is a time and a place for doing full crown cases, but I think it's very, very rare. And I think, who can afford that? What are we, $60,000? How many of your patients can you really help like that? And how many dentists are really qualified to go do a full crown case? I've never done it. I don't want to do it. It's just, there's so much detail involved there, and there's so many places that you can get lost. So this is a way to be able to treat the patients, do it well. I mean, it really fixes the problem. It treats the case. And you're using composites, so could it stain? Yeah. Could it chip? Maybe. Can you fix it easy? Yeah. It's a little composite. If you need to add some back, fine. You need to polish it, go, it's okay. Go ahead and polish it. There's going to be some maintenance, but we're not replacing crowns. We're not dealing with all that big stuff. It's easy. So, yeah. So, that's my story, and I'm sticking to it. And I want to show you, thank you. So where I learned all of this stuff, these guys here are basically my heroes, Hal Stewart in Flower Mound, Texas, and Craig Harry in Overland Park, Kansas. They teach this in Texas at the Texas Center, texcos.com. I think they are on the cutting edge of occlusion. And then for the Bite FX, if anybody's interested, they are offering I can't remember what the discount was, but they wanted to offer that to this particular group. I found that the patients that we see in particular, they want to know why things break. More than the rest of the world, the patients that we see, crown breaks, they want to know why. So it's a perfect group to do that with.